So starting our afternoon, an exciting afternoon program, we're going to start off with an excellent and very germane topic this afternoon. And it's my pleasure to introduce an old friend, the Honorable, meaning, an honorable, by the way, means confirmed by the United States Senate, as you may know recently. That's no small feat in itself anymore. Admiral Brett Giroir. He is the Assistant Secretary for Health for the U.S. Department of Health and Human Services. And his talk this afternoon, very, very germane, tackling the opioid epidemic at the federal and state level. Admiral Giroir is the Secretary's principal public health and science advisor who oversees the department's broad-ranging public health offices, whose missions include HIV policy, women's health, disease prevention, and human research protections. He also oversees the Office of the Surgeon General in the U.S. Public Health Service Commission Corps, as well as a number of key presidential and secretarial advisory committees. Dr. Giroir serves as Senior Advisor to the Secretary for Mental Health and the Opioid Policy. In this capacity, he is responsible for coordinating HHS's efforts across the administration to fight America's opioid crisis. He is both a physician and a scientist who has served in leadership positions in the federal government as well as academia. He has published nearly 100 peer-reviewed publications and holds patents on a number of biological inventions. Admiral Giroir concludes, after he concludes his presentations, he will take questions from the audience as time's permitting, and hope we have a few minutes, Admiral. And so if you want to ask questions, just find yourself a microphone. And in the meantime, Admiral, the mic is all yours. And my good friend, it's great to have you here today. Thank you.
Thank you so much. I really appreciate it. It really is a great pleasure of mine to be back here in Texas. I came here for training at UT Southwestern, spent about 22 years there, and have also done time in the faculty at A&M. As well as Baylor College of Medicine and on scientific advisory boards at MD Anderson. So I've touched a lot of the institutions here, and I'm, of course, really pleased to be back, really talking at the policy level today about combating the opioid epidemic. As Gordon said, I was confirmed last February, so I almost made it a year, which is no small task. I won't say it almost took me a year to get confirmed, but that's another story. But about 6 weeks after I started at HHS, the Secretary asked me to be the Senior Advisor for Opioid Policy, meaning I'm sort of the drug czar for HHS. And the reason is because it's a big organization, $1.3 trillion, 90,000 people, with efforts across the spectrum that really needed to be coordinated and led and done in a really cogent way. So since last March, I've been in this role as Senior Advisor for Opioid Policy. So I may not have all the answers. I know I certainly don't, but I certainly know what a lot of the questions are, and we'll give you the download on any question you have related to this. Or if you want to talk about other things within my portfolio, that's really fine as well. This is going to be at a policy level, and I know people here are from the physics community, the engineering community, molecular biology, across the spectrum. So we're going to start everyone off on the same foundation about how bad the opioid crisis is, and what are some of the administration and policy actions. And I've been asked to focus on really what are some of the research questions that are really out there, and I will highlight them both from the official NIH kind of perspective, and Francis is very, very, very deeply concerned about this issue, takes it personally. We work almost on a daily basis on this, but also some of the things that bother me, trying to understand where to put these billions of dollars, how to get the benefit from them as we attack this crisis. So that's where we're going to start. So to everyone start on the same page, this is the latest national data on the extent of opioid misuse and opioid use disorder or addiction in the United States. It comes from SAMHSA, the Substance Abuse and Mental Health Services Administration, from something called the National Survey of Drug Use and Health, which is published in September of 2018 for September to cover the year 2017. It's based off a household survey of 68,000 households, so it's our densest data about the extent of the problem. So about 11.4 million people misused opioids, meaning using them outside of the way a doctor would prescribe them, either to you or to someone else. About 900,000 used heroin, and over 500,000 use both. Clearly an enormous disorder. 2.1 million had an opioid use disorder. That's by the Diagnostic and Statistical Manual classifications, mean these are addicted to opioids. It changes their lifestyle, it changes their brain chemistry. They need to be in treatment and approached as having a disease. 53% obtain the last pain reliever from a friend or a relative. This is why it's so very important to not only limit the amount of prescriptions, but to get rid of prescriptions that you don't need anymore. Every 4 months, we have a drug take-back day. We're averaging about 950,000 pounds of opioids collected every quarter that are just excess that people throw away. And something I will emphasize multiple times, which is why there's so much research looking for new targets, new opportunities for pain therapy, is most people misuse opioids because of pain. If we do not solve the pain crisis, both acute but mostly chronic pain in the US, we will not solve the opioid crisis or other crises that we are facing. There are lots of numbers. The official 2017 numbers as published by CDC are really astounding. Over 70,000 Americans died of drug overdoses in 2017. About 48,000 of those were due to opioids. Opioids itself represents 20% of all mortality in the 18 to 24-year-old group. 20% of all mortality due to opioids. This is the most important public health crisis of our time. It has killed more people than it had all the modern wars, kills more people every year now than actually auto accidents. It's something that needs to be faced with a whole of society approach, from the most basic of basic science to the most attacks on the socio-demographic and the social determinants of health. When you look at what's killing people, it is primarily the synthetic opioids or fentanyl. Fentanyl is a commonly used drug in all hospitals. I'm a pediatric critical care physician. Fentanyl, to give you the respect we have for this, it would only be able to be used by an anesthesiologist or a critical care physician in a hospital setting, but it's on the street in truckload quantities right now. So it's predominantly synthetic opioids, fentanyl, to a much lesser degree heroin. Natural and semi-synthetic, which are really the prescription opioids, have dropped off in their mortality, and we can talk about that if you want to know that sequence, but that's what we're looking at right now in 2017 data. Now, every month, National Center for Vital Statistics publishes a rolling 12 months, so what happens in the latest 12-month period for which time that they've collected data. And I bring this up, this is the December 2018 data that looked back on the 12 months ending in May of 2017 versus 2018. You see the kinds of trends. Heroin deaths are going down, prescription drugs are going down, methadone's going down, synthetic opioids up almost 25% in deaths. But don't forget cocaine and psychostimulants, meth. We have an incredible problem with cocaine and meth resurging. This is usually mixed drug use, both intentional and also accidental. New data from the CDC just came out, different database, but it looks that 70% of cocaine deaths also have opioids involved. So this could be mixed use, multi-substance use by people who have the disease, or more and more likely, we have fentanyl contaminating the cocaine supply, the methamphetamine supply. We even have marijuana laced with fentanyl these days. It's a very, very potent drug, about 100 times more potent than heroin. Very, very deadly. So, that kind of grounds us is where we are. Secretary Azar, my boss, has had 4 pillars of his most important issues for this administration. The first is ending the opioids crisis. Second is drug pricing. You've heard a lot about that with some very far-reaching, very bold steps to lower drug prices within the country. Health insurance reform, and finally, value-based care. And he's asked one person at the senior advisor level for each of these pillars. So I have the opioids tasking. So that's why I can speak relatively definitively about what we're doing throughout HHS. And I also function in the interagency. And let me just assure you, every week there's an opioids cabinet meeting at the White House run by Kellyanne Conway, where the leads from every agency are around the table. Housing, DOJ, agriculture, we're all around the same table, VA, DOD, making sure that across government we're talking with each other. And there's a phone call during the week as well. So there's 2 meetings of the opioid cabinet every single week really working on this issue. So our strategy is pretty clear, and this is the 5 high points, but I think it's very important for everyone to understand that we absolutely need better addiction prevention, treatment, and recovery services. And addiction is a disease. This is a public health emergency. You cannot arrest your way out of the opioid crisis that we're in. It's a public health issue. It requires treatment. It requires social services. It requires wraparound care. Better data. Really, we did not have the mechanisms to even understand who was dying, where they were dying, how they were dying, and do that in a real-time basis that we can intervene. We do that now. Better pain management for all the reasons I talked about. We are in this crisis primarily because of overprescription of opioids. That was a 2-decade phenomena that got people physically dependent. It got them addicted. When the drugs started going out of the system, they went on the streets. When they got expensive, they went to heroin, which was dirt cheap, 90% imported from Mexico, and now fentanyl, which I'll show you is primarily imported from China, either directly in the transnational mail, or it goes to Mexico and Canada and then smuggled across the borders. So those are very cheap, they're very deadly, and that's the progression. Better targeting of overdose reversing drugs. There's a drug called naloxone. If you're in the medical field, you've used this before. It is a miracle drug. If you are comatose and barely breathing, it can be injected, it could be squirted in the nose, which is the #1 form, and it really revives a person, brings them right back. Now, if you're dead, you're dead. But if you're not dead and you're still breathing and you still have life forms, it wakes them up immediately. Doesn't cure their addiction, doesn't cure their disorder, but it gives them a second chance at life, and it's a great chance to channel these people into actual treatment and recovery services. And of course, better research. You know, the public thinks we know everything about everything. I deal with this every day. Why do we need to do work on neuroscience? Don't we know about the brain? It's like we're still kind of stirring cauldrons about how the brain is formed and how the interactions occur. The same thing with pain management and also addiction, and that's the NIH Heel Initiative, which I'll talk to you a little bit about the opportunities for this group. If you're really interested, that's the 5 sort of bullet points. We published in September really all the strategies we have. There are about 70 strategies, 73 strategies that represent about 700 efforts at HHS. And these are still high-level things, but please look at them. If we're missing something, email me, because I really want to know what we're missing, because we want to cover all grounds right now until, as I talk about a little later, we could mathematically model and understand really what policies will yield the best results. I have no doubt we could spend $100 billion a year and not make a dent. We have to be really smart in how we spend our money to get the greatest inflection points to move the needle on this disease. So, basic slide, but I want everybody to know, whether you're a Nobel laureate or you're in physics, that this is a disease and we have to approach it with a public health effort. And there are absolutely 4 components that have to be there. #1, medication-assisted therapy. You know, we don't treat infections without antibiotics. We don't treat other diseases without medicines. And it is absolutely proven true beyond any scientific reasonable doubt that medication-assisted therapy greatly improves people recovery. And there are a number of forms of it. Naltrexone, which is a complete antagonist that blocks the effects of opioids. Methadone, which is a complete agonist that can only be given in specialized programs. And buprenorphine naloxone, which can be given by any prescriber who undergoes an 8-hour, or if you're a nurse practitioner, 24-hour training, is really the mainstay of therapy to assist people to regain their lives, to lose their cravings, and move back into society. Medications are good, but it's not as effective if you don't have psychosocial support with education and coping skills. And let's not forget recovery services. If you take a person out of prison, move them back into with no home, no education, no job, no social support group, they're going to be right back. So recovery services are very important, whether that's in community settings, faith-based organizations. And finally, naloxone, which is that reversal drug that's so very important, that can bring a person literally back to life, not literally, but almost back to life, and give them another chance. And I wanted to highlight that because we have a lot of opportunity. New data, again, from the CDC, looking at prescription opioid overdoses, illicit or combined, about 41 to 45% have a bystander present. So you're actually overdosing with a bystander who's right there. This is why it's so important to have Good Samaritan laws and have naloxone there. But only 0.8% of prescription opioid overdoses have had naloxone administered by a bystander, and only 4% across the board. So we're missing the opportunity to save 40% of the people who die of these overdoses just by getting naloxone out there. We can talk about this, but there's a standing order. You can get it in 48 states without a prescription. There is great movement towards potentially having an over-the-counter view. But another thing that we really want to emphasize is co-prescribing. The CDC advised that if you're on a high morphine dose, equivalent dose, MMEs, or you're on benzodiazepines like Valium, you should have this co-prescribed by your physician. Nationally, co-prescription is about 0.3%. And even in the Medicare program, we're publishing this in the academic literature, the rates are astoundingly low, and they're completely driven by 2 states who have mandatory co-prescribing. So if you're talking about giving a person an opioid, a powerful opioid, or they're at risk, please co-prescribe naloxone. It's something we want to do, and I put out an advisory in December in order to make sure that people understood that this is a very important aspect. There's lots of money that gets put out there, and I'll talk to you about the new opportunities, but there are billions of dollars invested across the board to support states in their efforts to beat the opioid crisis at the state and local level. Our primary philosophy is that we insist that you're evidence-based, but we provide money for the states to do what they think is better for the states. We don't believe that I can tell you what you need to do in Austin or what you need to do in Los Angeles, but you need to be evidence-based. So for example, if you have a program that doesn't provide MAT, medication-assisted therapy, we don't reimburse that. It has to be evidence-based. It has to be in line. As the evidence progresses, we will heighten that as well. The NIH Heel Initiative, again, this is very personal to Francis Collins and Nora Volkoff. Work with them all about it. This is a major initiative. The FDA is now, the NIH is investing about $1.2 billion a year in this overall effort. And for the NIH Heel Initiative, for improving treatments and enhancing pain management, even in fiscal year 19, they're investing $850 million in this. So a very heavy investment. And if you look at this list, and you could have all my slides, and this is all published there, it goes from everywhere to how to provide care in a public health setting to the most basic molecular biology of finding new targets for pain, to intracellular signal transduction, depending on if an opioid is more addictive on the side, has more respiratory depressant or not. So this is a very, very, very broad portfolio from the most basic to the most public health that the NIH will continue to invest in. And we certainly anticipate at least $500 to $700 million a year continuing through Congress, at least for the near term on this effort. So how have we done? You always hear gloom and doom, and we are in the midst of this crisis, but we are making a difference. And of course, you can start wherever point you want. I started in January 2017 at the start of this administration, where we have to claim responsibility for whatever is going on. Total morphine milligram equivalent, sort of a measure of the total opioid prescriptions, has dropped by about 26%. Now, I do have nightmares that as we drop the prescriptions, if we don't couple that with medication-assisted therapy, we will drive more people to heroin and fentanyl and have more deaths. So although we want that to decline, you're going to see a very soft touch by me and this administration about regulating this, because it has to be done indigenously to the medical and scientific community with attention to medication-assisted therapy. People who receive buprenorphine, MAT, up 22%. Naltrexone, another MAT, up 47%. And prescriptions have increased 338% for naloxone, still not enough, but getting there. The number of individuals from 2015 to 2017 who misused pain relievers has gone down by 1.4 million. Again, a good sign. Nothing to claim victory, no victory dances here, and the number of individuals with disorders has also increased. Some new data are a little bit more heartening as well. This graph is the number of first-time heroin users, and we kind of feel this is a bellwether, because as people transition from prescription to street drugs, it is usually heroin. So between 2016 and 2017, the number of first-time heroin users in the U.S. have dropped by over 60%, 63% by the NISDA survey. So again, we're seeing some headway in this regard. And finally, if you look at the rolling 12-month mortality, so this is published every month by the CDC. The new version will come out tomorrow at 10 a.m. in the morning. I've been briefed on it already, but it's highly embargoed. But if you look at the rolling 12-month mortality, you will see that, and again, this is 6-month in arrears, because it takes 6 months for all the death certificates. It looks as if we have plateaued on the curve of all overdoses. Now, opioids are still going up slightly, but all overdose deaths have plateaued and are starting to come down. Nobody's claiming victory. Nobody's slowing up. We've got to keep moving, but it looks like all the efforts that we're doing are making some dents. And my goal, which I told the Secretary and we've told the President, is that I believe that if we do our policies correctly, we could reduce U.S. overdose drug mortality by at least 15% by January 2021, which will reflect data about 6 months before that. And that's clearly what I'd love to do more, but if we don't save lives, nobody's going to be happy with whatever prescriptions or anything that's happened out there. So when I close, I want to talk about some upcoming funding opportunities and issues. I only have 2 minutes left before this. So there will be a lot of money coming out from the Substance Abuse and Mental Health Service Administration, another $500 million being channeled to the states within the next few months, along with a number of other grants. The CDC will again award about $300 million to strengthen data systems, and HRSA will really work on the health professional side. Again, all upcoming within the next few months. I checked with all the leads at their agency, so this is sort of upcoming, publicly available. Last few things I wanted to say is I was asked to give you some research and policy issues from my point of view. Surgeon General and I kidnapped this child who was a baby who had neonatal abstinence syndrome. His mother has recovered. His name was Stetson, and we were at the New Parkland. It was really a great day. First Lady and I do a lot of work together on neonatal abstinence syndrome, which is one of her issues. And I just think that's sort of emblematic of how we need to transition from a crisis framework into an integrated, sustainable, predictable, and resilient public health system. We shouldn't rely every year on whether Congress is going to pass $1 billion of grants here or there. We need to build that, and how do we do that? One of these issues is how do we change the reimbursement system, and CMS is doing a variety of new reimbursement systems. Remember, they have a $1.3 trillion budget. So if you want to change the way healthcare system does, you change the reimbursement into more novel, integrated, inclusive, holistic models. Secondly, understanding, engaging, and remedying the underlying root causes of addiction, suicides, and other behavioral health issues. This is a symptom of underlying diseases. This was published by Don Burke at UPitt in Science in September. And what it basically said is, although we've made ourselves feel good at different times, we're on an exponential curve in mortality for overdose deaths since the 1980s. There are deeper societal issues going on. We need to attack them. We can't just fix the opioid crisis because we'll go into another crisis. And by the way, the cartels already know. They're moving away from opioids back to meth and cocaine as we start attacking this. So they are very, very nimble. This really is a struggle, an epic struggle in the US. So we need to get to the underlying issues and fix it. Real-time modeling and prediction of health policy effects. I want to know if I do something tomorrow what the effects are, and we don't have this. The only paper published that I know of is out of Stanford, out of Margaret Brando's lab. She's an engineer who put together a model system that tried to predict what would be the effects of policies, how they would affect in the short term and long term. I need the engineers and mathematicians doing all the variables together to know whether if I spend $1 billion here tomorrow, what the effect is going to be or whether it's going to be counterproductive. I would say high throughput ultrasensitive detection technology. How do we detect fentanyl that we don't have to search every single car, every single person coming over? Very important issue. We shouldn't rely on police in Nebraska to stop a suspicious truck that has enough fentanyl to kill 26 million people in it. We're never going to stop this. We can't arrest our way out of it, but if we can have high throughput technology to detect this coming in, it will help. And finally, we need to develop national infrastructure to track the outcomes. We're working on a very innovative project for neonatal abstinence syndrome, tracking nationally through one of my White House fellows, Shayla Jelani. So the last thing I would say is the National Academy of Medicine is very active. So I work with Victor Zhao. We're co-chairing a national steering committee on this National Academy of Medicine Action Collaborative that has 50 of the largest organizations working together in a variety of areas: education and training, research, prevention, prescribing guidelines and evidence. And this is a natural for everyone in this crowd to be involved with. Webinar is coming up in February, collaborative public meeting in April. So the National Academy and Victor and I are on each other's speed dial. We actually work together very closely to bring the academic community in with the public health community, with the government community, and everyone around the same table. So again, I wanted this to be an introduction to the next science session. I really appreciate the opportunity, and I'm happy I have about 6 minutes for questions. Fire away.
So could you speak for a minute about the rising price of drugs, and speaking specifically about the opioid crisis? I note that between 2014 and 2016, the price of naloxone, the auto-injector that was being manufactured, went up almost sevenfold.
Yeah.
And so what's being done about trying to mitigate that?
So I basically think this is a talking point that is almost irrelevant. And the reason why is that 95% of the market is by the intranasal Narcan that has had the same price maintained throughout. So the government price is $75 for 2 doses. Hard to argue with that being a price. Evzio was crazy. You're right, it went from $100 to $4,000 list price. This is symbolic of the middleman getting the cut. So the patient gets basically the shaft. The price is there. The patient pays all the deductible. It gets back put to the consumer. Very big problem. The good thing is that it offered no particular advantage over the other, so the market went that way. And as you may or may not know, Evzio has come around, so they now have a product that's $176 now. Their $4,000 has been decreased to $176. I've met with them a dozen times. That's available now, and it'll have a generic by mid-2019. That'll be $176. It does have some advantages, the auto-injector, particularly for elderly population. But in general, naloxone is affordable. If you're prescribed it, most copays are less than $5. Medicaid copay is $1. The price to the government is the issue you brought up. But I don't think naloxone pricing is the issue. It's distributing it and getting people to co-prescribe it. Yes, sir. Or yes, ma'am.
Brett, that
Cheryl.
that was just an amazing talk. Thank you so much. How does what is going on in this country compare to what's going on in other places around the world? And
Yeah.
this is not just a U.S. epidemic. And are we coordinating with other countries as well?
So we are increasingly coordinating. I'm also the U.S. nominee to the Executive Board of the World Health Organization. So I've been very active globally in this regard. Canada is seeing a great upsurge right now. So our closest, and I think it's this week, we have a 90-minute meeting with the health minister and the chief medical officer of Canada. We've been working for the same kinds of issues. So we're clearly seeing it there, the UK to a lesser degree. But the last World Health Organization meeting, for example, was in Kazakhstan. And Kazakhstan has a huge issue with heroin use, primarily from Afghanistan, their imports. So we are seeing this more or less starting in a variety of different countries, starting in Canada, UK, but I would have never expected Kazakhstan has the problem. So we're having increasing bilateral summits. Many places don't embrace MAT, so a lot of the discussion is about stigma and MAT. I think MAT is good here, but we still have a lot of stigma for people wanting to get care. So yes, it's a growing international problem. Where it goes, I'm not sure, but it is on the global stage and growing.
Thank you.
This is a person could buy a kilo of fentanyl from China for about $1,500 is the price, and that could be sold for $3 to $4 million. So you do the economics, and there are enough bad people who want to do that to support what we're doing here. So it's going to be an ongoing struggle. Yes, sir.
Hi, I'm so glad that the federal government has really taken a leading role in this. I practiced for 25 years as a primary care physician, emergency room physician, and my experience and the data suggest you're right saying that the reason people are originally prescribed narcotics is for pain relief, but it's not why they get addicted to them. They get addicted to them because they're self-medicating for mental illness, for the large part. And until we fight that underlying cause, we're going to be massaging the edges of the epidemic. And unfortunately, mental illness is treated, it's funded differently in this country, it's inadequately treated in this country, there's an inadequate infrastructure for treating it in this country. And until we fix the underlying cause of inadequately treated mental illness, we're not going to get at the cause, we're not going to really make a big dent in the opioid epidemic. In your slides, you mentioned a couple of times, you talked about, they mentioned addiction, suicide, and other behavioral health issues. And it's the other way around, I think. It's the behavioral health issues was driving the whole thing. And it keeps coming up. My doctor gave me these medications and I got addicted. That's true. What's missing in the middle is that your mental illness you felt better, so that's why you took them. It wasn't because of your pain, it was because of your mental illness.
So your points are absolutely greatly taken. There are individuals who, and there are a number of stories about people who have an acute pain crisis. They get 30 days of OxyContin and then they're there. But there is a tremendous amount of comorbid mental illness with this. And you're right, Parity is not on Parity yet. The infrastructure is not there yet. The workforce is not there yet. Ellie McCann's Katz, who runs SAMHSA, first psychiatrist to run SAMHSA, believe it or not, is kind of fearless in this regard. A lot of the things we're doing, for example, community health centers, FQHCs through HRSA, we are dramatically expanding the provision of mental health and substance use disorder treatment within the FQHCs, and they're up by like 70% year over year doing that. But you're absolutely correct. We're very sensitive to this issue, and this is one of the things I could wish I could wave a wand overnight, but I can't. But we're working on that, and any suggestions? Again, Ellie is tremendous in this regard, spearheading that.
Okay, we're just going to have one more question, and I think we've already heard. So the Admiral will be here during the break for additional questions. So, Admiral, one more question, ma'am.
Sure.
These are scary statistics, and it was a fascinating presentation. You showed an encouraging slide right at the end, a leveling off. What do you attribute mainly might be the reason that we should see a little encouragement in that leveling off?
So even Margaret Brando's academic model said there's no single policy that's going to beat this. It's going to have to be a combination of a number of policies all working together in conjunction, some of which in the short term may raise mortality rates, but in the long term reduce it. And we talked about the tension between decreasing prescribing and moving people to heroin and illicit drugs. We are very cautiously optimistic because about everything is moving in the right direction that we know, but you don't know what you don't know. So prescriptions are down, people entering therapy is up, opioid overdoses are down. We have really good real-time databases from emergency rooms that are not public yet from CDC. So the trends are moving in that direction. Can that be disrupted tomorrow? Absolutely. It could absolutely be disrupted tomorrow. We are in the process of a fragile, partial success story that needs to continue to move. The SUPPORT Act, things don't work very well in Washington most of the time. The SUPPORT Act was great, right? Both houses of Congress, bipartisan, bicameral, supported by the president, signed by the president, with literally billions of dollars of funding and some great provisions that we couldn't fix unless Congress acted. So I think on some of the major public health issues, the real debate is, shall we give you $20 billion or $100 billion? There's no debate on the substance of what needs to be done and how it really needs to get there, because I testify all the time. I work just as well with both sides because we're all trying to be on the same page. So I think for this, the crisis is so bad that everybody's working together, and I feel encouraged by that.
So, Admiral, thank you very much. Very, very well done. Thank you.
Thank you. Thanks.